today's presentation will be recorded. We will have this available to those of you that did purchase the webinar today, and you can find that in an email that will be coming to you once that video is ready to go. And without further ado, we are going to get things kicked off. I will hand it over to our president, Dr. Mark Lazar, and he will introduce today's feature presenter, Dr. Matthew Nejad.
Thanks, Carla. Appreciate it. Thanks. Great to see everyone here. Wow, everyone from so many different countries. It's incredible to see this and pull everyone together for this. I love this. All right. Well, today we have the distinct pleasure of introducing Dr. Matthew Nejad. He is not only one of the most amazing biomedic dentists and aesthetic dentists practicing in Beverly Hills, California, but he's been a wonderful mentor and educator to many dentists throughout the entire world. Now, many of you have heard about his Nejad Institute. It's an incredible place to learn about biomedical dentistry. So anyone who's trying to be satisfied the CE requirements through the Academy of Biomedical Dentistry, I recommend you take his courses at Nejad Institute. There's so much information to learn from him. He's not only been a great friend to me, he's been a great friend to the Academy of Biomedical Dentistry. He's a fellow of the Academy of Biomedical Dentistry, and he's been serving on our board of scientific advisors, along with two of his mentors, who have been Dr. Alleman and Dr. Pascal Mann. Now, Dr. Nejad has received his DDS degree from the University of Southern California in dentistry. He's considered one of the top key opinion leaders in the dental industry. He's a member of the ADA Standards Committee on Dental Products, and his areas of research and interest are adhesion, polymerization stress, residual stress, biomechanics, occlusion, and aesthetics. I've referred a number of patients to him. He's phenomenal. He does incredible work. I always love seeing everything he does, and it is a real honor to have him here to take the time to answer the questions and answers with all of us. So please take advantage of that. Ask all the questions you can. And without further ado, I want to introduce and turn this webinar over to Dr. Matthew Nejad.
Thank you for that introduction, Mark. I'm really excited to be here answering these questions. We're trying something different, so I hope it's actually very valuable and we can, really get to specific things that people want to learn about. And I think it's going to be a really cool experience. And so I look forward to answering your questions. If we have to cut anything a little bit short, we just have to give everyone fair time, but I'm going to try my best to answer every question with as much detail as we can get through in this format. So should I just go ahead and pick the first question?
I'll give the first question. So we have the first question here. It's for, it's regarding white spot lesions. So for patients with a suspect spot of early demineralization or a white spot lesion, what range of treatment options do you recommend and why?
Okay, so for white spot lesions, so one of my favorite ways depends on where it is, but basically if we're talking about an anterior tooth, icon infiltration, resin infiltration has been really good. I've used that probably 10 to 15 times. It doesn't come up too often in my practice, but I bring it up anytime I see it. I try to mention it to patients. And what I found is some patients, it doesn't bother them. So I'm really not trying to press the matter, but I've had really good results with icon resin infiltration. And what I found to be a really good strategy with that is to first start with whitening. And this is something that my mentor, Pascal Manier, had always mentioned. When you whiten around white spot lesions, the first thing that happens is oftentimes the white spot lesions become super accentuated and they look like they're getting worse. So you tell the patients, don't worry, you're going to keep going through that process. You're going to notice it, but just keep whitening with the custom whitening trays. But at some point, the concept is that as the surrounding tooth structure becomes a little bit whiter, the contrast becomes less. So it tends to make them already improve before the infiltration. And then you get the benefit that if you're going to infiltrate, you won't have any issues long-term if the patient wants to whiten later and you've infiltrated those spots and so on. So I like to do it that way. And I have a case right now where the patient's doing resin infiltration followed by a whitening followed by resin infiltration next. The other thing that I like to do is mega abrasion for some cases, especially if it's deeper. Sometimes if there's like surrounding areas that are discolored as well. So I use, in the traditional technique, it involves using like a diamond round burr slowly to remove a little bit of structure, but I use air abrasion and then bond over that area too. But more and more I've been leaning towards infiltration. I think it's like a really good way to do it. And you can do much more than you can imagine. You know, you think it's limited to like small lesions, so on, but I've had really good success with doing it for multiple teeth, the whole anterior section, and so on.
Okay. Again, this is a question and answer. It covers all range from basic questions, most advanced questions. This is a simple question, but it's important. Is the composite that replaces dentin and composite, is the composite replaces dentin, the composite replaces enamel different? And if so, what types of composite should they be?
Okay, generally, so for the ideal, so there's a lot of differences of opinion on this. It doesn't, you know, this is one of the things I like to talk about. So first of all, you can do excellent composite restorations using the same material. So having been trained from Pascal Magnier in dental school, and then for years having been in touch with him, also having been in touch with great clinicians from all around the world, you don't need to use a different composite for your enamel layer and your dentin layer to get successful results. What you need to do is have a good adhesion, you need to have good isolation, but the details about different composite for enamel and dentin become much more significant when you're dealing with really large structurally compromised teeth. So not for the routine restoration, not for the moderate restoration, but when you're looking at alternatives, like for example, trying to do a direct restoration instead of an indirect, if you're between decisions, then it becomes more and more significant. And the strategy is to use a dentin-like modulus of elasticity for the dentin replacement. And like one that I really like to use a lot is APX. But lately I've also been doing a lot of EverX posterior for some of these as well. Almost every composite, every restorative composite that's not a flowable is in the range of dentin. They range from 10, I mean, not the bulk fills and everything, but regular packable filled composites are in the range of 10 to 20. So like on average, you're going to be somewhere in the range of dentin, but you're shooting for 12 plus, 16.7 is APX. So that's what I use for that. Now for the enamel layer, you want to not only have the optical properties, but in addition, even higher modulus of elasticity, higher wear resistance. And there is fewer and fewer composites that do that. One of the great ones is Majesty Posterior. And so that's the one that a lot of people are using. I like it a lot. It has nice shades that work pretty universally for posteriors. But with that said, I've also been experimenting with other composites as well. Like if you use an EverX type short fiber reinforced composite, and then you cover it with essentially anything over 10 modulus, I think you're still going to get a very successful restoration if the tooth isn't like you're rebuilding an entire tooth. If you're dealing with even a medium to large direct restoration, there isn't only one way to do these things. And that's a lot of what I think people misunderstand, that if you're not using this, you're not going to succeed. I think what you need to succeed is going to be good isolation, good adhesion, good technique, controlling polymerization stress, but there's a lot of different ways to accomplish that goal. I've had great talks with some of my other mentors and friends like Richard Young doing it one way. Like people have had great success doing these things. If you're doing high quality dentistry with some of the key ingredients that you need, it's not necessary that you do different materials. So you could just do APX all the way through for a large percentage of direct restorations and still have excellent results.
Okay. Can you please discuss the evidence behind decoupling with time? The person wants to know what research has led the biomimetic masters, such as yourself, to advise waiting 5 minutes for the bond to mature to dentin prior to building composite layers greater than 2 millimeters.
Yeah, so let me come back to Zoom here. So adhesion is a reaction. It takes time. It's been well documented that the bond strength improves with time. That's regardless of dentistry or engineering. If you look at any example of adhesive ribbon tape, adhesive hooks, things you use around the house, they say that the bond matures over 24 to 48 hours. That's because it's a reaction and it takes time. And if you're stressing the bond while it's forming, it doesn't re-heal itself or reattach itself. So the example I give is if you put that, I have it on my door right now, I have an adhesive hook where I hang my dry cleaning from for it to be picked up. it hangs 15 or 20 pounds from it. But if I put it on and I immediately start putting high stress, if I hang my dry cleaning on there right away, it's going to literally lose its adhesion or weaken its adhesion, and it's never going to recover. But I waited 48 hours or so, and now it's been there for over 2 years, and I hang my laundry from there all the time. So coming to dentistry, these polymerization kinetics, they're across a lot of different papers that look at like composite polymerization kinetics. It takes time for the bond to form because it's a reaction. At the same time, the polymerization shrinkage is happening during that time. One classic paper is by Davidson. It's in the 1980, but it's called The Competition Between the Developing Dentin Bond and Composite Polymerization Shrinkage. There's plenty of others that I cover in my mastership program, but the concept is clearly there that polymerization is a reaction. And if you can understand that if you are trying to form the bond and instantaneously trying to stress it, you're weakening its full potential. So that's the concept. And 5 minutes is not exactly an arbitrary time, but it's the minimum threshold where if you look at the polymerization graph, it basically looks like it plateaus at around 10 minutes. At around 5 to 10 minutes, you're getting in the vicinity of 90%, 80 to 90%, but not necessarily with our exact materials. These are from older studies, but the science and engineering is the same. The bond still takes time to form. And even if it's not our exact same material, you're not going to overcome the fact that it takes time for these bonds to form. And it becomes much more important when you're doing something that has a high shrinkage stress. One more thing I want to throw into that is that everything you do that's indirect and you do immediate dentin sealing, that's been well documented that the bond strength increases at 24 hours and then even higher upwards of 2 weeks later. So it is pretty well established that bonds mature with time and that stress is the opposing antagonist to bond formation. So that's where these things come from.
Okay. Speaking of indirect, how do you temporize your non-retentive indirect restoration?
Okay, so I do a couple of different ways. So one of the original ways that I did for many years was based on using Telio, inlay, and onlay, which were also known as Fermit and Fermit N. If you haven't used them, they are kind of like gummy materials that you would pack up, condense, shape, and cure. And I would Vaseline, 100% Vaseline or glycerin to prevent it from adhering to my IDS and resin coating layers and everything. So that's what I used for years, and I would shape it and I would clean the embrasures, everything. But more lately, I've been doing it with bisacryl materials. My favorite one is actually from Panasil or Ketenbach actually, and it's called Vasalis. It is like Luxatemp, but it's extremely strong. You can feel it, like literally, like if you try to break it in your hands, you can feel it. If you try to even adjust occlusion on it, you can feel its strength. So I like to do that, especially for the full overlay, but I really don't recommend that for the inlay intracoronal restoration unless the patient's like from out of state or something and you're willing to cut, you have to cut it off or chip, you have to like kind of, it's going to get stuck somewhere. So you're going to have to like cut it in half and use a crown tapper to get that off. But on a overlay, that works amazing. So what I do is I take a pre-op putty, or even better, a wax up before the appointment. If we have planned this and it's, part of the schedule, we do that often with our intraoral scanning. And so patient comes in, I have a putty and I use that material. I let it lock into the embrasures. Sometimes you can roll up Teflon tape, put that Teflon tape under the gingival margins. And that way, once it's set, you can pull the Teflon tape out and you kind of have a area for passing floss and using water pick. I don't find that mandatory either. If you get a little bit of gingival inflammation throughout the process, I've been doing this way for about 10 years now, but if you get a little bit of gingival inflammation, it's temporary. It doesn't cause any permanent damage. And I always tell patients that the temporaries are not the best part of biomedic dentistry, but the final is worth any sacrifice you would give. The best temporaries in the world are crown temporaries, and they can be almost as good as finals, but it never would I recommend changing your paradigm based on the temporary issues. And if you get good at these, I remember I had them come out all the time. I got better and better and better at them. And nowadays, I probably don't deal with temporaries coming out about 90% of the time. I think that's about as good as you can get with these types of techniques. I also tell patients if it comes out and it's a few days before the appointment, I'm not concerned. If it's a week or two before, I am concerned about drifting, because with immediate dentin sealing, resin coating, all that stuff, the major objective is drifting of the tooth.
Okay. Can you also discuss when you prefer, I know the gold standards materials we talk about of adhesion in biomedicine are the Optibond FL and the SE Protect. So the question is, can you discuss when you prefer using Optibond FL and when you prefer using the Clearfield SE Protect and why?
Yeah. So yes, I can explain. A lot of it has to do with two different factors, and there isn't 100% a decision tree that I can recommend. I think you can use either one of them with excellent results 100% of the time. But I had one mentor using Optibond FL, and that's what I grew up, or I was raised on doing that type of dentistry. Met another mentor, David Allman. He was in the SE family. He swore by it and was passionate about it. So I ultimately started giving it a try, and I was very scared because I was having zero problems with Optibond FL. So you're risking everything. One of my big concepts is don't change things unless there's a strong reason for them to improve. But as time went on, I saw a couple reasons why you should know how to use more than one bonding agent. I was getting patients that were saying, I don't want this material because my material reactivity test showed that. I'm not a huge advocate on doing that type of testing, but I figured, you know, if I can be comfortable and gain confidence in the science with more than one way to do it, that would be a huge benefit for me. The other thing was, as I started using it, I actually noticed differences in how it looks and how it feels, all the way down to how, like, if you cement a restoration with, let's say, SE Protect's bond, it feels different. It lubricates a little more. It feels a little bit stickier when you're trying to do resin coating on a crown. It stays in place a little better. And when you're trying to cement a restoration, it seems to flow a little bit better. So little preferences like that came up over time, but still to date, I kind of try to play a game where I do different things, different days of the week. I try to find what makes sense for any given scenario. Like if you have a crack, I like to heat Optibond FL. Research shows that if you heat it, it increases the bond strength. So if I have a crack, I want to infiltrate into there. I want to get a little bit of penetration in. These are some concepts that, again, in engineering world, crack penetration and using epoxies to kind of seal into the crack have some science behind them. So I use that for that. If I'm doing a direct restoration, lots of times I'll use Optibond FL because I like to do total etching or selective etching of the enamel. I want to have phosphoric acid on enamel, and it becomes a little bit complicated to do that with SE Protect, but I've done it that way too. So there is no exact reason except that some materials don't survive. We've seen that happen with like cementable material, like what was it? Z100 went off the market and people had a panic attack about what they're going to use to cement. So I think it's important to have a few different options and to really understand that the science of biomimetics does not come down to one material. And that's really why I use two different materials. All right, let's look at some other questions.
When you're using a, the next question here, it's a multiple part question. So I'm trying to figure out how to break it down for you. Question is, first of all, when do you use a dentin substitute? And then when do you go to a semi-direct intra-orally? There's more questions.
Start with those two. Yeah, I'm looking at it right now too. When do I use a dentin substitute? I mean, every resin composite is I'm not exactly sure about this one, so I'm going to try my best on it, but I use the dentin substitute all the time because every composite I use is a dentin substitute to some degree. I don't really use any non-dentin substitute type materials. Maybe the question has to do with when you're doing an indirect restoration, when do you like maybe put a bio base down and build up some of the dentin instead of doing a larger and larger indirect restoration? I think that's maybe where it's going based on the question. So with something like that, I would say that if your restoration's over 3 millimeters, like my ideal restoration size, if it doesn't involve additional preparation, is 2 to 3 millimeters for an indirect. If I have more than that, I want to build up the foundation, the bases, block out undercuts, elevate margin, whatever it is that I need to do with Dentin substitute material. So I think that might be the direction that was going. Now, when do you go semi-direct intraorally? I never do that. That's a technique that I think is totally fine. But you know, the resulting anatomy, the time it takes, like I try to prioritize. So there's no right or wrong answer, but in my office, I try to prioritize the patient's time, intraoral time. So I don't want to build a semi-direct restoration intraorally. I'd rather take a scan or impression, temporize. It works out better for my economics and the patient. And it's not really an issue for my patients to return for another visit versus sitting there and in isolation or in the office. But there's no reason you can't do that. It's a perfectly acceptable restoration. I prefer to go indirect more often than semi-direct. And if I was doing semi-direct, it would be out of the mouth. I would take an impression, pour it up, and do it where I have full control. So I can get anatomy, staining, layering, all that stuff in the best. That's how I would do it personally. There's more to the question.
More to the question. Person also asking about the deferral and chamfer and saying, when do you switch from a flat non-retentive preparation to a mechanical furrow with a small chamfer? And if you were to see a full mouth that needs to be rehabilitated with very, very compromised teeth, with almost no furrow left, are you choosing to restore them or not based on what you're seeing?
We should do these are some in-depth questions here, but let's try. So when do you switch from flat non-retentive preps to a mechanical ferrule with a small chamfer? I don't often do, I don't even think I do a mechanical ferrule with a small chamfer. That's not something I do. So I do, first of all, I never do like literally flat. I follow the cuspal planes to the best of my ability unless the tooth was already prepared flat and I feel like extra removal is not necessary. But you're fine to do totally flat. I tend to follow the anatomy. I tend to do chamfer for a combination of aesthetics and also ease of cementation. When you're totally flat, you don't have that positive seat. It makes it a lot harder to position your restoration exactly where you want. If you've ever tried it, it wants to slide, buckle, lingual, creates a challenge for delivery. And we already have a challenging delivery with all the other steps and good isolation and all that stuff and the heated composite. So I don't really want to invite more room for those types of issues. And plus aesthetically, it looks the best. And even functionally, it really mimics the concepts of the occlusal, I'm blanking on the terminology here, the compression dome concept from Milicic. So I think all those things in mind, I don't tend to do flat. When do I do a ferrule is when I really don't have any biorim left. When I don't have any tooth structure that's supragingival, if I'm building up, if I'm basically trying to save a tooth that has very limited to no tooth structure left, especially no enamel circumferentially, then I'll try to get a mechanical ferrule or mini ferrule, even if it's just 1 millimeter, by using a fine burr, good isolation, dropping 1.5 millimeter subgingival, because the studies and the research shows that in those scenarios, that's the best possible way to restore that. But if I had 2 to 3 millimeters of tooth structure supragingivally, then I wouldn't put a ferrule on that. I would actually restore that with the traditional concepts that we just talked about. Well, the biomimetic concepts that we just talked about. I wouldn't take that opportunity and remove the remaining biorim by prepping a ferrule into it. And let's get to the last part of this question. When you rehabilitate a mouth with many very compromised teeth, virtually no ferrule, do you choose to restore them? I'm not sure I follow this. So I don't think I've come across a mouth with virtually no, like, does that mean a mouth full of like root tips? I've done actually a case similar to that early in my career. And what we did is what I described. I actually did do little mini ferrule buildups. They had all been root canal treated. They were already non-vital or infected, but most of the time we're talking about still having the opportunity, even in a badly compromised mouth with biomedics, to restore them without needing to do those things. So even in a very badly compromised situation, I'm usually able to find ways to preserve vitality if it's not already necrotic or devitalized.
I think you did a great job answering that question.
Thanks.
I like that. The next question, I can appreciate where it's coming from. The question is from someone in Greece. They were saying, isn't biomedical dentistry too brand oriented? And the reason why they're asking the question is they're saying that everyone is doing DME with APX. Should we not open the range to the right products of the products that we use? For example, the reason why he's asking the question is he can't find APX in Greece, so he wants to know why can't what other products can be used for dental replacement, other things. So what do you suggest for him?
I think it's a very valid point he brings up. And that's why, so look, if you come to take my training or to take David Allman's training or Pascal's training, you're going to get whatever works in our hands. We're most comfortable recommending products we use all the time. And I hope that makes sense. It's very important. We don't know every single material on the market. I definitely don't. Speaking for myself, I don't know every material on the market. I've made it a point to expand my comfort zone and really try to understand more and more that certain materials have excellent properties, but not so excellent that they make alternatives unusable, you know? So with that said, I think you can do DME, deep margin elevation, with any restorative composite that has a higher modulus. I would be shooting for modulus of elasticity above 10. You know, like I would look for the common principles that I'm looking for. Something that's easy to handle, easy to compact, has good properties, good polishability, not super low modulus of elasticity. I want to have something that's closer to 10 or more. APX just happens to be 16. It handles well. It has kind of the best of a lot of different properties I look for, and it handles very well. But like, let's say another great one that you can use for deep margin elevation is this one called Enamel Plus HFO from Mysterium. It's a brand of composite that comes in universal Dentin colors 0 all the way up through 7. It's got some good aesthetic properties. The enamel looks beautiful and really mimics the optical properties of enamel, the refractive index and so on. So that material is good too. And I've used that not for that purpose because I generally use APX, but I could recommend that if you can't use that. But then from there, you can use other materials too. You're not going to see failures because you use Filtech Supreme there instead of APX. It's just the one that we're most comfortable with, use the best, use the most, and has some of the best properties. But I promise you, if you have good technique, good isolation, everything else, it's not going to come down to which composite you use there. And that's the problem. That's why I'm saying it's a good point. That's the problem, that like, I know you can't all use it, but it's also hard for me to recommend materials I'm not familiar with. We'd have to sometimes get into, I've never used, like, you know, Curare, some of their composites in different countries are totally different names entirely, but they're either identical or slightly varied. And it's hard to keep track of everything. So, you know, we have to then go back to kind of the objectives and the properties. I think the big thing is to try to avoid using a flowable, try to avoid using low modulus or simplified bulk fill materials because they have lower modulus, and try to prioritize the technique, the isolation, and the final outcome.
Great. Next question is, how do you handle a biomimetic restoration for upper second molar when a patient presents with an active grinding parafunctional habit?
Okay. How do you handle the biomimetic restoration for an upper second molar when the patient presents an active grinding parafunctional habit? All right. So, I just did a mastership lecture on this today. Essentially, I mean, we were talking about cracks and fractures. So first thing is the cause of, you didn't really say, okay, so let's say you have parafunctional habit with or without a problem on the tooth. Your goal is to try to control the parafunctional habit in general. So I am big on occlusion, and that's where I'm investing a lot of my time to either researching, reading, and also developing my comfort zone and occlusion. So when you see parafunctional habits, your restoration is supposed to mimic natural teeth, and natural teeth fail under parafunctional habits at some level. So I want to control the problem and restore. But when I'm restoring, I would essentially ignore the parafunctional habit, because my restorative technique already includes mimicking the natural tooth to the best of my ability. And the natural tooth is best optimized and designed to handle anything you throw at it. So I'm not going to go put a crown on it. I'm not going to go put zirconia because they're a grinder. I'm going to rely on good adhesion, good materials, good isolation. So I restore on some of the heavy, like I've restored with lithium disilicate a second molar on a patient that cracked an intact premolar, totally really heavy clencher grinder, no restoration, nothing. But I also address the parafunction by educating, reviewing, trying to get him into occlusal guard. I mean, I don't think there's any predictable way we can cure bruxism clenching, but I think we can educate more people. I think it's very important that more and more people protect against essentially occlusal disease, but occlusal problems that take many years to manifest.
Right. Yeah, it's very important to manage under the functional, the stressful envelope of function. I mean, I know that people have different bite forces, and some people could really have these strong masters that can really grind the heck out of these things. So yeah, we're to know your
but we don't change the restoration essentially for that. I mean, maybe depending, I'll go from intracoronal to full coverage, something along, depending on the details, which I don't have in this question, but short of that, I'm not going to put zirconia or full, did I say full coverage? I meant occlusal overlay, maybe, but not like full crown. That defeats the purpose of understanding how stresses transmit through a natural tooth and how a crown doesn't do that any better than a well-done biomimetic restoration.
Great. And again, I know that you have your Nejad Institute, you have a lot of courses that you're teaching on the fundamentals of these principles. So again, I'm encouraging every single person who wants to learn further detail about this stuff, take some more of these courses in depth, these hands-on courses. You learn a lot from these things. Another question coming up is, if you have okay, so this person is new to the concept of biomedical dentistry. So they're saying, how is biomedical dentistry different than a mercury-free dentistry?
Oh my gosh, so different. Mercury-free dentistry doesn't say, okay, I can do mercury-free dentistry by doing gold restorations, right? That's mercury-free. I can do mercury-free dentistry by doing full coverage zirconia crowns. So biomedical dentistry, the goal of biomedical dentistry isn't specifically to avoid mercury or amalgam. It's to mimic the natural tooth, to restore the properties, the stress, the biomechanics, the aesthetics, all the different things. The tooth is our model, and our goal is to replicate that. And so it just so happens that using mercury-free restorations or not using amalgam restorations is part of that, but it's not the same. I've seen a lot of patients that come to me having had either holistic dentistry or even people that said they did biomimetic dentistry, and all signs of the restoration and the account that the patient gave me points to the opposite. No rubber dam, bulk fill technique. They asked for the materials didn't add up. So there's a lot of differences, but I would say that while biomimetic dentistry is mercury-free, mercury-free dentistry is not biomimetic necessarily.
Good answer, definitely. The next question is, I'm trying to figure out how they're asking this question.
I know, I see this one. Is it the gradient one? Yeah.
It basically, I'm guessing that we have a sequence of the way we do things in biomedical dentistry, everything from the way we prepare the teeth to the etching, the priming, adhesive, the resin coating, all the different things. So I guess the gradient of how we're going from the beginning to the end, asking if that the system that we're using is more scientifically proven.
Nope, definitely not. So you can try to stretch and make it fit your narrative, but it's not. I had somebody ask me this in my mastership program, this concept of a gradient of modulus elasticity. I don't think there's anything wrong with it, but I'm confident that there's no scientific evidence that it's any better than just doing immediate dentin sealing, resin coating, et cetera. You don't need to create a gradient of anything. You're essentially creating a gradient when you do the resin coating, but to go from Clearfill SE then to Optibond FL, you're overcomplicating things. What are you trying to solve? Pascal has been doing 2 millimeter increments and Optibond FL for 20 years. He's the father of this type of dentistry. And now all of a sudden we have to put Ribond in and we have to do a gradient and we have to do a backflip before we restore the tooth. It's not how it's supposed to be. It's really frustrating to see these things. You're fine to do that stuff, but please don't be under the assumption that that's what makes it biomimetic. There's great advancements in dentistry that just come from using good materials, good isolation, good technique, good adhesive, and understanding the major components of polymerization, shrinkage, and stress. Anything beyond that is not well documented. I can assure you that.
Okay. This next question, I know I get a lot with my patients. And a lot of dentists out there who are trying to, I guess, answer it when the patients will ask them the questions or wanting to know the answer to get into biomedentistry. The question is, how long does a biomedical restoration last in comparison to a traditional mainstream or regular dental restoration?
Okay, so when a patient asks this question or anybody asks this question, what do you think is the number one variable in how long any dental restoration lasts? Okay, and if I ask a patient, I like to let them think about that for a while. If I ask a dentist, I hope the answer jumps out at you. The real answer is how long something lasts really comes down to the operator. There's so much different variables in our techniques and how we do things that just because you say you did a biomimetic restoration doesn't mean you did it to the same level and standard that I would. It might mean you do it better than I do. It's just the point is the operator is very important. So it's not possible for me to comment on how long other people's restorations will last, but I am comfortable to tell my patients that my biomimetic restorations function and last like permanent teeth in your mouth, because permanent teeth in a mouth that's pristine don't tend to have problems over a lifetime unless there's a trauma. Permanent teeth in somebody's mouth that is under heavy parafunctional forces, doesn't control them, doesn't brush, doesn't floss, they're going to experience a high rate of failures that are avoidable, but not being mitigated. So it depends. But I kind of overall expect everything I do to last over 20 years in my hands, over 20 years. And when I tell a patient, like even on veneers, I'll say the same thing. I tell them that doesn't mean it looks like it does on day one. Everything ages, including natural teeth. You can control that, but it lasting means routine maintenance like chipping and wear can happen, but they don't require a replacement. So 20 plus years. And I have examples of 10 plus years in my own hands. And I have examples from my mentor, like Pascal, some of his patients I've been treating that are going on 16, 17 years. And we can see, in his hands, they're doing great at 16 plus years. And I've even seen restorations in other dentists' mouth done by really well-known dentists that are easily lasting that long as well. But it's not an easy question to answer because it's, I would say it lasts longer. If you do everything by the book and great isolation, it should last much longer than simplified restorations, traditional techniques. It prevents catastrophic failures and really preserves the concept of keeping your teeth for life, because traditional concepts require more removal of tooth structure and minimize our long-term options. So I think in anybody's hands, if you do the best quality of biomimetics, you're going to get the best results.
Absolutely. I mean, it really depends where you're starting from. I mean, you're starting from a point where someone says, look, I was told my tooth needs to be removed, and I was told maybe you could possibly save it. And you have a very compromised tooth that's very cracked. You have a very compromised foundation to begin with, but the chance of it lasting doing these techniques is going to be much greater than if it is something other than this.
Absolutely. Totally agree.
So the next question is, how would you treat severe enamel acid erosion on all teeth?
As usual, address the cause. So always address the cause. I've done full mouth rehabilitations on a previous bulimic patient. I'm doing a full mouth rehabilitation on a patient who denies bulimia, but must have some sort of acid erosion component. So my first step is to figure out what it is. Is it diet? Is it reflux? There's a large category of people that fall under something called silent reflux, where they're unaware of it. They have no other signs of, hold on a sec, they have no other symptoms that they're aware of, but the signs are there for us. We see the teeth, we see the erosion. Oftentimes the lower anteriors are spared because it's further away from the back of the mouth and the tongue kind of protects and covers it. So I send them for evaluation, and we have diagnosed quite a few people after seeing an ENT that have some degree of reflux. And unfortunately, the solution for that is just an antacid. But with that in mind, restoring the tooth adds protection. It seals the dentin, slows down the process. If the process continues, you will have a repeat. So I try to say I can restore it, but it's in your hands to do your best to prevent it as well. So we get back to the idea of addressing the cause, but then I restore it with a adhesive approach. Same way as usual, immediate dentin sealing, resin coating. Either if it's just protect the tooth, protect it, seal it, maybe fill the areas of erosion that are pitted, where you can actually create a little bit of room for composite. If it's more severe, it's raise the vertical dimension, restore the teeth, overlay them, do the full workup. Depends on the patient's goals. But I've done everything from just kind of sealing, protecting, and slowing down the process to trying to fully reverse it, depending on the goals.
Okay. I'm trying to ask this question the right way. About regarding the protocol of a molar indirect restoration, I guess one that would traditionally need a post, how would you prepare?
Okay, how's the protocol for a molar indirect restoration that traditionally would need a post? Okay, so the purpose of the post is to retain the core, and the purpose of the core is to retain the restoration. In an adhesive restoration, the purpose, none of those exist. The adhesion is what retains our buildup, and adhesions what retains our final restoration. So in those cases, what I would do, first of all, if it's one of those ones that has very limited remaining tooth structure, no biorim, anything, I would try to create even a mini ferrule. 1 millimeter ferrule has been shown to give us a little bit of improvement there. But if you cannot, that doesn't mean I can't restore it. It just means I have to be very careful to control laterally directed forces. I want to verticalize the occlusion, minimize forces that would result in shear stresses, and really focus most of the pressure in compression. So with that in mind, we would fill any area that you would deal with the post, I would do with restorative composite. If you literally had a previous post space, you're going to have to either use a post or a dual cure material. There's a technique that we cover in my course using Ribond as like a method of filling the chamber. So it's like a rib-on post, if you will, but I don't need or want that. That's just what I do if I have something that I can't cure past where I can reach. So let's just say we don't have that scenario. I would do composite buildup or Everex buildup, which is short fiber reinforced composite, shape it into a mini tooth preparation, not a huge tooth preparation, but something like a 2 millimeter buildup. And then the remaining material would be my lithium disilicate indirect restoration, because in a tooth that's that badly compromised, you've lost effectively all of the natural tooth's innate stiffness. And the best way to recover that is not to do more and more dentin buildup at that point. It's to err on the opposite side with a thicker lithium disilicate restoration and a smaller buildup. There's a few variations where if you have a CAD/CAM machine, you can also do a Lava Ultimate or composite based milled endo crown, use it as a buildup later. There's these varieties, but I do the way I just described.
Would you ever use Everex as a resin coating on the IDS, and why not press Ribond into Everex instead of APX?
Over-engineered, maybe, because I do. So why not? Okay, why not use Everex as a resin coating on the IDS? So I do use Everex Flow as a resin coating on the IDS. I don't pick up a material today and start using it 100%. I start introducing it little by little. I've had great success using Majesty Flow, and it's still something that I like a lot. It's easier to handle. It's okay. Everex Flow is an amazingly easy to handle material, but it's not amazingly easy to get a uniform 0.5 millimeter coating with it. It's still easy in other ways, and I love it. It feels kind of like applesauce. You can place it where you want. It doesn't slump, and it's got potential for great properties in terms of using it as a resin coating material. But it's not easy to coat your entire prep and make it even. When you use your probe to spread it, you've created a hole. You got to either try to spread it more, wait a little. I tried using a brush. With that said, I have no problem with using it, but I also had no problem using resin coating with Majesty Flow. And depending on the scenario, if I don't see an advantage, I can pick and choose. And if I use Everex Flow, sometimes I want to cover anyway with something to smoothen it for the for the impression taking. So like, you know, Everex Flow doesn't have the smoothest surface because of the fibers. So if I'm going to be using something on top of it anyway, and I don't see a major advantage to using it, I don't. Plus, what if studies come back and show that for that purpose that Everex Flow isn't as good as resin coating? What am I seeking to gain? So when I introduce it, it's when I can understand that the properties of the fiber give me a protection against cracks, which is a whole topic that I covered today, and I can't go into right this second. But short of that, I don't think you need to use it every single time, and I definitely don't think you need to place a rib-on into Everex. I think that would be over-engineering it. You know, like they both have fiber. They're both known for arresting cracks or preventing stresses from resulting in the existing crack from spreading.
Okay. When you're doing a full coverage indirect restoration, if there were no previous boxes that were present in the old restoration, are you breaking the contact interproximally, or do you leave the margins at or within the contact area?
Breaking contact. So if I'm doing a full coverage, I break contact. You need to be able to cement and finish that margin. 2, your lab needs to be able to give you a precise fit. You're not saving any significant amount of 2 structure. You're not doing yourself any major good by saving that 2 structure there. So I break contact. I've experimented a little with separating contact, but you have to make sure if you separate, you still have to drop low enough to have a natural emergence profile. So I generally just try to minimally separate contact following the natural emergence profile of the tooth. And I have done it a few times the way you're describing, but it ended up being more difficult, more problematic, and overall just not as good of a final result as if I did it the way that I should have.
Here's a question. Why aren't there more biomedic dentists? It seems like there's a large patient demand of a few dentists. That's what we're here to train biomedic dentists. We want more.
Yeah, I know. So, you know, if you're where I'm sitting, it seems like there's more than there's ever been and growing rapidly. You know what I mean? So like, let's go back 10 years ago and I thought everyone was doing this and nobody was. And now it feels like everybody is doing it. So I guess it's a matter of perspective, but I think basically what it comes down to is it takes time for science and innovation to spread. That's a fact. 2 is if you can think back to dental school, there's no way you could learn all this stuff 100%. I learned because my mentor Pascal was there. I did a selective program where I did advanced study with him. And even then, I didn't fully understand that this was not the common educational concepts taught until I graduated. So I think it comes down to more faculty at more universities, kind of updating the curriculum, and also students putting extra time, because there's no way that this is just the one composite course you cover. And you know what I mean? It's advanced. I think biomimetics should fall under like an advanced master's program or a master's in operative dentistry or something like that. But dental schools should prepare like 70% of the fundamentals or something along those lines.
Yeah, I mean, you're so incredibly lucky to have had Pascal as your mentor in dental school. I mean, I don't think people realize what a blessing that this was to be able to be there and to learn from this wonderful master of biomedicalistry. I mean, people around the world don't understand these, appreciate these techniques. I mean, that's our mission as the Academy of Biomedicalistry, to be able to bring this to people. And now we have a webinar with people from all around the globe joining in to hear you speak and learning about these techniques. you have your Nejad Institute to teach people about biomedical dentistry and learn more about the proper ways of being able to save teeth in the most minimally invasive way possible. It's a whole different level. So this is catching fire. I have patients reaching out to me through the website saying, oh, I heard you do biomedical dentistry. So it's a big deal. Our website has a search for a biomedical dentistry feature, so we can get people to help find people who are practicing the proper biomedical dentistry, and the ones who want to practice it have channels, take courses like yours to learn how to do it the right way. So it is catching fire, it's getting there, and people are starting to ask for it, which means that if there's a demand for it, then the niche is going to be filled, because people will start learning these techniques so they can satisfy their patients. So it's great.
100%. Yep. The only other thing I want to say though is that you can do some degree of biomimetic dentistry. Like, in other words, if your practice demographics don't allow you to do 2-hour appointments and all the things that go into doing biomedics, you can at least cater towards your patient base with the best version of what they are expecting or paying for. I think insurance-based dentistry still needs to be ethical. I think the problem is overhangs, poor margins, sensitive teeth that just like, oh, it was a cheap filling. That's the problem. We have to either fight the insurance companies or find ways where you can still give a satisfactory product, because not everybody wants to invest. Like, I really do think biomedic dentistry is the gold standard of dentistry, but it's also like the saying that everybody should have the best car in the world or so on. Some people just need to, take care of the problem, get out of pain. And even if that means it's cheaper and it gets the job done, we have to have options that are ethical for that. So I try to teach those concepts. I try to show how you can do a bulk fill, but do your immediate dent sealing resin coating. So it's not the best restoration in the world, but it's much better than a leaky bulk fill. It's protected against having sensitivity, pain, and that can fit a practice with the demographics that need that type of procedure. So, and that doesn't make it totally biomimetic, but it still makes it on the spectrum, and it makes it a good restoration, as opposed to giving something that's just right off the bat, not like substandard.
I'll say one more thing. People also may not have necessarily called it biomedical dentistry back a couple of decades ago, but I know people like Ray Bertolotti have been teaching these techniques since the mid '80s. A lot of these, advanced bonding techniques, and it's grown more into what we recognize it as now. But these techniques have been around. The science has been around a lot of these things since the '80s. And we just keep looking at it. And Alleman helped to put these things together. Ray Bertolotti has been teaching about these things. So, this has become more of a recognized protocol, methods and protocols that we're doing now.
Yeah, and we can thank Instagram too, because I think a large percentage of people here are seeing these things online, learning about it. But you have to also be very careful, because it comes off as if these things started yesterday and there's only one way to do them. So for me, it's very frustrating to see that, like, oh, you have to do this. Like, I had this great discussion with Pascal the other day, and he's like, why is everyone putting fiber everywhere? Like, Pascal doesn't use fiber. Do we think he's not a biomimetic dentist? Do we think his work is not exceptional? It is. It really, really is. And the science is there. And a lot of the groundbreaking science did start there. No, you know what? I take that back. It didn't literally start there. He advanced it exponentially. And so the point is, we have the opportunity to teach these things online, but I think it's very important for people to make sure that they truly understand and they're not propagating things that are just their opinion and passing it off as fact, making sure they don't confuse people, because before you know it, we have people going down the wrong path and might lead to some problems, when right now the current path is doing exceptional. So I think we have to be cautious of when we change things. We have to be cautious of thinking that it's only one product that can do it, because it's really not one product. And these are the things that kind of make me want to spread as much as I can, because I'm not set on only one product. I'm really set on the end result, not the product.
Right. I think you answered this question before to some extent in one of your answers, but the question was, can you use Majesty Flow for deep margin elevation?
You can use anything you want for it. It's not the best option in my opinion, though it has been studied. there was a paper that looked at that versus heated composite and incremental layers. The consensus was that the most continuous margin after thermocycling was 1 millimeter layers of heated composite used for DME. It's acceptable, but I personally wouldn't do that myself. So with that, going back to the thing, if you did that and everything was meticulous, your isolation was great, you did an amazing onlay, do I think you're gonna like literally have everything fall apart? No. Definitely not. But I just think it's not the optimal material for that purpose.
What do you think about Biodentine or glass ionomer composite as a dentin replacement for those who don't have Everex? And which type of glass ionomer composite, if so, would you select? And there's a follow-up after that.
So I prefer, depends on what we're talking about, direct, indirect. Let's say we're talking about a direct, then there's a really good option for using glass ionomer in what's called the super closed sandwich technique, where the glass ionomer doesn't come into contact with dentin. The bond strength of glass ionomer to dentin doesn't compare, and to methacrylate based adhesives. So it is not optimal. I think the best way to use glass ionomer to minimize polymerization shrinkage and residual stress in the tooth would be in the super closed sandwich technique. And the fatigue testing that Pascal did was supporting of this concept. So the idea is you do immediate dentin sealing resin coating or whatever, then you build up your proximal wall with composite, then you use the glass ionomer as the dentin replacement, but it's touching your adhesive or your resin coating. And then on the occlusal, it is covered with restorative composite again. So it's like a mega filler. And I think that's great, but I wouldn't do the same by letting that adhere to dentin, because at some point, remember, stress in an ideal biomimetic restoration, the forces transmit like a natural tooth, which means that from the occlusal, things either travel down the side pathway or basically work their way into dentin horizontally and axially down the tooth. And when it hits the glass ionomer layer and the weaker adhesion to dentin, it's expected that that's going to magnify or increase the stress at that interface, because lower bond strength interfaces don't transmit as effectively. So I don't see a need for it when you can also do the technique I described. So you're getting the benefit of the lower shrinkage, but you're still using it as a mega filler in the central and really minimizing the impacts that can occur from that material failing, leakage, etc. But if you don't have Everex, we have Everex Flow, and I think that's being studied right now. So I think that's going to be a good option. And also, it's totally fine to still use composite in incremental layers. You know, these are, it wasn't that incremental layer of composite was not acceptable. It's just, it has a higher residual stress, and we have some ways that seem to be controlling that and should result in improved success long-term.
Have you ever used a C&B Metabond for bonding PLV or Emax restorations?
I have not. I read a paper on it recently, but I've never used it, so I'm really not too familiar with it. PLV, is that porcelain laminate veneer? So I always use, is that what that PLV is? Yeah. I always use heated composite, APX, or that composite I was telling you about that you can also use for margin elevation, that Enamel plus HFO from Mercury. It's one of those two is what I use, and I've used Z100 in the past, but it's not on the market. Apparently it's not on the market, but I haven't tried, but I've heard from numerous people that it's no longer around, or it's very limited in the supply that's remaining.
A question regarding long-term results. Someone's asking, what are your long-term results with non-retentive adhesive dentistry, and what studies are available to read related to long-term success with overlay designs?
Don't have any studies off the top of my head. I know some exist, but the problem I have is the operator is the big part. You know, like long-term success with overlay, if we're talking about 10 plus years, it's going to come down to the clinic, the standards, the isolation, the adhesion protocol. So it's not really identifying what matters, but I can tell you from my own success, I have 11 years of practice now. On posteriors, I actually have one failure that I have attributed to, that I'm aware of, first of all, because not every patient comes back, but one that I'm aware of, and it was a very small posterior overlay, and it wasn't a bad failure. It was actually a fracture with one portion of the restoration debonded, tooth totally intact. It was very thin, and it was literally like the distal portion of the second molar. And I redid it without changing anything, and it's going on longer success than the first time. It could have been an isolation issue. I looked at the restoration, and I was seeing that I had resin coating intact on the tooth, and I had cement on the restoration. So something in the process, even perhaps a gap or a void or inadequate polymerization. But point is, I've had very good success. I haven't had repeat or repetitive failures or any that I'm aware of. And so I think that if you're looking for a study to prove it, it's going to be really hard to find something that's comparable to your clinic. But there is plenty of studies that look at just overlays in general, and they have pretty good long-term success. You know, even without biomimetic principles, they have good long-term results. But I don't know any off the top of my head. I got to pull them from my database.
Yeah, there's a lot of questions. You know, people are trying to wrap their head around biomedical dentistry and get away from the retention-based dentistry. This question again is asking, so biomedical restoration for a large cavity will save more tooth structure and will last as long or longer than a conventional crown. I just want to reassure.
Yes, definitely. So if now the caveat here is, do you really understand the whole concept, everything? Because doing a lithium disilicate onlay is not a biomimetic restoration. Okay, biomimetic restoration for something like that includes good isolation, immediate dentin sealing, resin coating, good quality impression, good quality restoration, good quality isolation again on delivery, best conditioning protocol for both the resin coated layer and the ceramic, both. You can't just let the lab condition and cement. You can't, there's all these things. The modulus of your cement makes a difference on the performance of your restoration. The bond strength of your restoration to the tooth structure makes a difference on its fracture strength, its fatigue. It prevents cracks and fractures in it because of the modulus of the material and the bond strength. So these all go into place. So if you are doing all those things, then I expect it to last longer than a conventional crown, and I expect the tooth to last much longer for the patient because of preserving more tooth structure, more options, more opportunities to keep the tooth vital.
Okay. This next question is asking about a class 2 restoration. They're saying that they have seen a number of biomedical techniques, and they, according to what they've seen, they think the proximal surface is built up with what they thought was a flowable composite, and later on the internal was filled filled afterwards. Can you explain the rationale for doing the technique this way, if that's the case?
Yeah, give me 1 second. The air conditioning is making a lot of noise. Do you see my phone? I'm going to quickly turn that off. I think it'll help. Someone mentioned that, so. Off. Let's give it 1 second, hopefully. Okay, I think it's still going, but it should turn off soon. So I'm going to read that question one more time, if you don't mind.
Sure, go ahead.
On most,
yeah.
Oh, go ahead. Go ahead.
Most
Thank you.
classes of restorations that I've seen using biomedical techniques, the proximal surface is built up with what I thought was a flowable composite, and then later the internal of the restoration was filled. Can you explain the rationale for this?
Well, that was a full. I can't 100% comment on what you saw, but what it should be is that the proximal surface is built up with a restorative composite, not a flowable composite. Okay, so building up the proximal wall first is a great strategy for a lot of reasons, but not with a flowable, material in that area. So, and it looks like we're talking about a class 2, so direct. Yeah. So I think that's probably either a mistake on, I don't think it's the best technique if that's what they're really doing, or it was interpreted as different. So I took care of the sound, and now my cat's making all this noise. He's licking bags. He wants to get fed. Okay, let's keep going.
So if money is not an issue for the patient, how do you decide if you're going to do a direct or an indirect restoration? For example, if you're replacing multiple cusps on a molar.
If money is not an issue for the patient, how do you decide if you will do direct, indirect, for example, replacing 2 cusps in a molar, 3 cusps? For me, if I'm doing cuspal replacement, I want to do, so when you put the question that way, if there's cuspal replacement involved, I prefer indirect. Just for some simple concepts, like for example, the enamel you're replacing has a high modulus that composite doesn't. Does that mean composite can't succeed in that situation? No, there's some good studies that show that. Opdam has done some studies that show really good results with that, but does that mean it's going to last as long? I don't think so. I think it's missing the concept of biomimetics and copying. Stop it, Tux. Stop it. Being such a bad cat. So I think the idea is that if you want to replace the cusp, you want to restore that enamel and on top of that, on top of everything, occlusion and getting that all dialed in the best way. I like to have it done on the model. So for me, the issue on when to go direct versus indirect, it more or less comes down to intracoronal restorations, isthmus width, and the patient and their occlusal factors. So if they have narrow isthmus, class 2, MO or DO, I'm always going to favor direct. If it's MOD, narrow isthmus, might still favor direct, especially with new research showing that EverX composites for even large MODs are performing similar or as good as inlays. So this is very groundbreaking. First time we're seeing that just in fatigue testing, they're able to stay on par with an indirect restoration. So those are where I do directs, but as soon as I get into cuspal coverage, my preference is indirect.
This next one's an aesthetic question regarding veneers, but with regards to interior guidance and end-to-end occlusion, you tend to adjust the incisal edges of mandibular incisors to gain broad contacts with maxillary veneers, or are you counting on the adhesion and leave the incisal edges, even if it means a more pointed end-to-end contact?
Which number is that? I want to look at the question. 27. Oh, there it is. Thank you. With anterior guidance and end-to-end occlusion, do you tend to adjust the incisal edges to gain broad contact with, say, or do you count on adhesion and leave the incisal edges even? Okay, so I just saw a patient the other day with end-to-end occlusions, like edge to edge, right? Is that what that refers to? You think?
That's what they're referring, or if it's just very, very, very tight.
Okay. If it's edge, so I just saw a patient the other day. She wanted to, 1, treat her TMD, and 2, improve that. She was aware of that. And my strategy there is first, to screen for, in her case, especially because she had symptoms when she would wake up, she had sore muscles, popping and clicking, but more importantly, like sore muscles, pain, discomfort, sometimes headache. So I referred for that. But what I want to do is orthodontically adjust if possible. And which generally is, I've done a few cases where we're able to realign things and position them in a way to improve. But her hang up was, can't we do just the Invisalign or the orthodontics and not do restorative? And I was explaining, you've worn them down, like positioning them in the correct position still doesn't restore anterior guidance, canine guidance. These are things that I've personally experienced in my career. I've had to do one case over early on where I didn't have good canine guidance and it was uncomfortable for the patient. He felt really locked in. The minute I changed it, everything improved. So I learned some valuable lessons on that case. I've also had cases where if I didn't have canine guidance, the more minor failure was higher chance of chipping or fracture of the lateral. So chipped edge happened on one of the cases. I repaired it and I treated the canines to improve the guidance pattern. But the idea that I have in general is that the bonding is strong enough to mimic what a natural tooth would do. I've never had an entire restoration debond in that scenario. I've had it chip on the edges, things that you would imagine would happen to a natural tooth in the same environment. So you have to plan that all in. So for me, I would, even if I was jumping it and the occlusion was tight, I would be fine, but I would at least try to control the forces with an occlusal guard. And you have to be very careful if it's that tight with the envelope of function. So you have to like test it out. That's probably an example where I might do a bonded functional aesthetic prototype where I can evaluate it with composite that's injection molded to see how it does. And if that does well, especially with an occlusal guard, then I can proceed. But that's not a technique I use often. That's just the time I would use it.
Okay. Next question I think is great. Okay, so Biomedical Dentistry seems to do things that appear to be of the highest quality, but that takes additional time and effort by the dentist. That should get translated to a higher cost for the patient. So how do you advise younger dentists that are under the insurance agreements that limit their fees to approach these types of patients?
I graduated 2010, wanted to do this type of dentistry, so I bought my first office. It was not an expensive office. It had almost no business to it. It was basically a startup with the equipment, 2 chairs. I treated it like dental school in the sense that I treated a morning patient and an afternoon patient. I was doing, I was in every insurance network. I was doing 3-hour class 2 composites for $50 on the worst insurance I was in. And I considered it my residency. I considered it the same as if I had gone to medical school and I was in residency. I was developing my skills. I was learning things. The insurance was, the patients appreciated the value they were getting, but I appreciated the opportunity to get to practice this way as opposed to being forced to do another type of dentistry. So my advice is don't be only focused on money because money comes later. Yes, more time and effort should translate to more financial gain. However, people find their values in other places. You might find your value in satisfaction. I know plenty of great dentists that do this just because they are more satisfied to do it. It's not all about money, but definitely if you're interested in doing it, you have to sacrifice one way or another. And I did for years. And little by little, I was able to raise my fees progressively. And at the same time, I got a little bit faster, I got better, I got more comfortable, and so on. So put in your time. Don't focus on just the financial end, be passionate about what you do, and the rest kind of falls into place. Hopefully.
That's a fantastic answer. I'll add one thing to that. You also make it back in referrals of new patients. Because people appreciate the care that you put into it. Even if they know that you're not making the most out of that procedure for them, they appreciate you saved their tooth. You helped them out. You were not pushing invasive, expensive procedures. And they appreciate and respect you, and they'll send more patients to you, and that's how you make your money back too in other ways.
Absolutely. When I moved, that was my first office. My second office, Beverly Hills, and I only have one office now. But in 2010, I graduated. 2013, I joined this other office. I actually purchased this office, but we ended up, the original dentist partnered back in. He fell in love with Biomimetic Dentistry, and he's still there with us. So you want to talk about this type of dentistry being fun and rewarding. He went from no loops to wearing 4 times loops, then 8 times loops. Now he wants 10 times loops. He's doing rubber dam. He's ready to dismiss a patient that won't tolerate rubber dam. He loves doing this type of dentistry, and he partnered back in, even though he sold originally. He said, I actually want right back in. Can I stay? So in that transition, my point was I had patients that came to me from my first office, which is so far away. The fees are more expensive here. Everything's more, my rent's more expensive. My first rent, I'll share, I don't know how many people will relate to this, but my whole office rent was $900 a month in 2010. Isn't that amazing? That was like, right? Like $900 a month for a dental office. It was Simi Valley. But by the time I left, it was $1,300, which was a huge hike over the years. Within 4 years, I had to renew my lease, but still it's cheap. Now it's 10 times that. And I charge more, but I still have patients that come. Like you said, they valued the work and they know the quality. And I firmly believe that what I do will be the cheapest long term. I really believe that. Like my fees are based on the time I put into it, but also the concept that I believe it'll cost the patient less long term. And if it doesn't, I feel a lot of responsibility for that. I'm not happy. Like when I had that failure on the posterior, I did that for free. He literally paid me in cash on the side, even though, like, I don't know why he did that. Like he could have just paid the front, but I said nothing. He tipped me essentially. He's like, no way, you know, that's above and beyond. So he paid me a little tip, but I didn't expect anything. I want my work to last, and I'm willing to go back on my fee and make it last. And I just have to play it by ear based on the patient. Have they disappeared and gone somewhere else, done no maintenance, and they come back with cavities everywhere? Or has my restoration failed? And do I feel like that's not really what I had, you know, sought to provide? And then I'm going to do whatever I have to do.
This next person is asking, I'm not familiar with this, maybe you are, they said, they're quoting people, Ozcan and Gresnik, I'm not sure if I pronounced that correctly, use silane before bonding on IDS. Is it necessary to do so, and won't it compromise the bond to enamel?
I do know it's Marco Gresnik, and I think there's a paper with Ozcan. I know Marco Gresnik, fantastic dentist, excellent work. I know he does it, and I know there's some studies on this, but I don't think you need to do it. I think if you do it, it's fine, especially if you do it with the right technique. You make sure you let it evaporate because hydrolysis is part of the reaction. Will it compromise your bond to enamel? That's one of the things. One time I was working on a prominent dentist who knows everything about these concepts, a very, very like leader in the field. And he told me to silane, and then he told me to go back and aerobrate the enamel and etch it. And it was because it wasn't a cementation, by the way. It was repairing of an old composite. Okay, very old, 17 years, where silane becomes very important at that point. But he said, go back. And later we were talking, he's like, we just don't know, you know, will it or will it not? So as far as I'm aware, there's nothing to show that it will lower your bond strength to enamel, but it might possibly. I think I read something recently that said it doesn't, so I'm not sure, but I can tell you that I don't think you need to do it, because all the studies that I'm using based on the bond strength are based on not using it. Like getting 50 megapascal bond strength to our immediate dentin sealed layer with the restoration is research Pascal did using a protocol without applying silane to it. So I don't incorporate that step because I don't know how much it can help. And we're already exceeding like the cohesive strength of the material anyhow. So I don't do it. Does that make sense? Our failures are occurring at the cohesive strength of composite. So it's not, I don't think we have an adhesive problem to our resin coated layer.
Right. And silane
if you've aerated.
Or ceramic filler in the composite.
What's silane is inside. Yeah, silane is in there.
It's
Yep.
more of a ceramic filler in the composite. It's for the ceramic filler.
From Ray, silane is for ceramic filler. Well, I know what it's for, but the question was asking, won't it compromise the bond to enamel? So silane is specifically to allow fillers to adhere to the resin matrix, completely aware of that. But the question was, won't it compromise the bond to enamel, as in if it contaminates the enamel surface?
Right. Perfect. Another question here is, what's your feeling on having a deep carious lesion near the pulp? Do you use a liner or just the dentin bonding system and the restoration?
I use just the liner and the dentin bonding system. The primary objective there is to avoid the pulp exposure. Okay, so if you can avoid the pulp exposure, then you don't. I've read a lot of this research. So the number one thing you can do to maintain pulp vitality in these deep carious lesions is start with a vital and healthy pulp, or at least the pulp that is consistent with reversible pulpitis. And then from there to not expose it. The minute you've exposed it, you've minimized the chance of success no matter what you do. That doesn't mean you cannot succeed, but that's my paradigm based on the research. There's a lot of consensus on this. But with that said too, I'm excited to introduce a great endodontist friend of mine who's going to be talking about the newest research on vital pulp therapy using bioceramics with, from what he's told me, upwards of 90% success rate. But that won't change anything I do. The concept is I'm going to avoid pulp exposure at all costs. If I did have one, this is probably how I would do it, but I avoid it very systematically. I've had only a couple pulp exposures that I can recollect over the past 10 years because I'm cautious on my caries removal endpoint. And I do just use my resin, my adhesive and resin coating, no additional liner.
Perfect. And I guess, you know, that just emphasizes that the first rule of biomedentistry is to keep the tooth vital at all costs, which is very, very important. Next question is regarding endo-treated teeth, though, since we're talking about non-vital there. How do you restore endo-treated teeth? And do you follow the same protocols of onlays or overlays? And do you use endo crowns or endolays?
I don't do endo crowns. I treat them, I basically treat root canal treated teeth with overlays, preferably, rarely partial coverage restorations, depending on the patient and some strong reason like preserving the buccal for aesthetics. I don't even worry about preserving the buccal for aesthetics because I can match it very well anyway. But sometimes I have those patients that really do prefer that. And most of the time, like probably over 90% of the time, full occlusal overlay. Don't do endo crown much. I've read a lot of research on it. I don't think it's any better or more effective. It might be simpler, but I think the best approach to use systematically is to build up the pulp chamber area with something like Everex, or even incremental filling with composite. If there's a canal space in post, that's a different story, but I specifically don't ask for any post space in the canal so that I avoid that. So I'm basically restoring the pulp chamber. And it also depends on how much tooth structure is left, because bonding is a function of surface area. So if I have a lot of surface area, I could even restore the pulp chamber with that sandwich technique, even using something like glass ionomer, but I need to have ample remaining surface area to retain my restoration. If I don't have that ample surface area without incorporating the pulp chamber area, then I need to make sure my technique prioritizes adhesion in that area. It's a little too complicated to go into much more detail, but I do not use endo crown or endo lay pretty like ever.
Another question, this is from someone, I guess, in the UK. They're saying that sadly, they don't think that many university facilities are teaching biomedics in the UK. You know, what's your feeling on that? Like, what would they do?
It takes time, and same here, but it's increasing. You know, we have some people that have been trained over the past 10 to 20 years. You know, a movement started, and it takes time for that to come to its full potential, but it's happening. And there's, you know, people graduating from different schools by other experienced biomedic dentists that have really helped shape the program. So all I can really say is ultimately, the dentist or the student has a large amount of control about getting educated on their own. Self-study is my preferred method of learning, but short of that, with time, it will change. But right now, if you don't have that option, I would say the only thing holding you back is your own commitment and time and maybe financial resources, but it's not out of reach. I've seen people travel from Chile. I've seen, you know, my course is now online, so people can take it from anywhere in the world. I tried to expand that, but even before that, people were traveling from Brazil, Chile, and it's just a matter of fitting within your budget and being a priority. And I think a lot of people, like I said, I sacrificed a lot early in my career and did composite. I didn't make money for 2 years, but I was learning valuable experience. And for some people, that paradigm makes sense. And if that's the case, you'll find a way.
Great answer. The next question was right before asked. This is a question for someone from Northern California, but it could extrapolate to pretty much anyone and everyone. What recommendations for a highly skilled, experienced biomedic dentist, you know, would you have, you know, for someone, you know, I guess I'm trying to look at the question, trying to think what they're asking from here, and they could just jump on and ask again. But what recommendation would you have for someone who's skilled and experienced? What would you do? How would you handle it?
Which number is this?
33.
Oh, number 33. Okay, thanks.
Asking exactly, but I guess generalize your recommendations.
That's pretty general.
Yeah, I wish there was a more specific question there. I think what you said before in the last question is answers that question. Basically saying anyone who's motivated to learn more about biomedical dentistry and hone their skills should be able to take initiative to take courses, travel, or do the online courses, your courses, other people's courses who are teaching biomedical dentistry, and do that. I think that's pretty much the best recommendation we can have for anyone who wants to hone their skills and become the best they can be in their field.
Completely agree. Completely agree. And I don't think I have anything. Let me just think for once. I experienced biomedic dentists in Northern California. I mean, maybe mention if you mean in terms of the quality of restoration, marketing, success of your practice. Just give me some direction on that, and maybe we can come back to it. But no, nothing short of what you just said.
Please bring another question there, more specific if you want it answered further. Okay, so another question is regarding Dr. Tagami had discussed that he brings Majesty Flow to the cabo surface in the box and sometimes placing it in increments. Do you teach this as well?
You know, I love Dr. Tagami actually, and he's a very prominent asset to this type of dentistry. And so if you notice, he also says they're doing a lot of their composites with flowable materials, and it's pretty well accepted in that area. And this is, again, going back to some degree of what we consider biomimetic, what can, you know, succeed if it's done with the best care, and also good isolation, good technique, all that stuff. So when it comes to using the flow at the cavo surface in the box, I think there's nothing wrong with it. I don't do that. People get overly concerned about doing something like that. Wait, in the box sometimes. So wait, hold on. If we're talking about you placing the flow to seal the band, you know, to kind of seal the matrix band so nothing gets out, I think there's nothing wrong with that. Placing it in increments, buccal and lingual, I think now we're talking about like restoring the box or something, the cabo surface with that. That I don't personally do, but I do think that small to medium sized composites can be restored with a good flowable composite like Majesty Flow, but it's not my first choice. And I don't think it's the best. It might be the simplest, but I don't think it addresses the biomimetic principles the most prominently. I would rather err on the side of safety, but he shows a lot of cases that he's done with that. So I think that with time, we might become a little bit more comfortable with things like that. But a lot of people who have done things like this with bad technique, bad isolation, bad adhesion have failed. So we're kind of in limbo trying to decide which direction we have to go. But I think it's safe to say that if you use a higher filled restorative material, you control the polymerization stress, you get good adhesion, then you'll get the best balance between your bond strength, your resulting integrity and strength of the tooth. Because if you do something that has, if you restore a tooth and you maintain the adhesion, but you don't have the original stiffness of the tooth, you might be able to succeed in a large majority of patients, but not in every patient. So I would rather try to make my technique more encompassing of a broader patient base.
Okay. Next person, I guess, is a student at dental school and saying they're not sure if they're handling the primer and bond well. They do have OptiBond at dental school. So they're asking if you have any advice on how to get the right film thickness for OptiBond FL and to use a gentle air spray or absorbing the excess with a clean microbrush, etc.
Good question. So OptiBond FL, about 80 microns thick, but if it pools, it can go, I think it's upwards of 300 microns where it pools, you know. And so what I would do is, first of all, never air thin it, okay? If we're talking about the bond, never air thin it. Makes a mess. You can just as easily absorb it with a clean microbrush if you need. But my first goal is to actually take it on a microbrush with what I estimate to be the right amount and place it far from areas that it would pool in, and then slowly work my way into those areas that would pool. I don't know how to describe the areas that would pool, but like, let's say undercut areas or areas where it might slide down an axial wall or something like that. But let's say it does pool, the easy way to address it is to take a clean microbrush, wick up the excess. I've even recently started using the ultra fine paintbrushes that Smileline has with disposable tips. That's also nice. It doesn't wick up, but it's really good for like spreading. It wicks a little bit, but it's best for spreading, bringing the material to the margin and so on. So I would say you have the right idea with the microbrush. Avoid the air spray for the most part.
Good question here about a microscope. Do you believe a microscope is necessary for the type of work that you are doing so beautifully?
I think so. Yes, but not a microscope. Magnification of, I do my best work I've ever done with 8 times magnification. I think I might do maybe even better with 8. When I went from with 10, I mean, with the new ones that I have coming, there's a limit somewhere, because you got to have the ergonomics, you got to have the field of vision and the comfort. When I first got 8 times loops, before I found those Oakley frames that I'm using right this second, it was very uncomfortable for me. My head would hurt, my nose would hurt. But when I found the right combination of things where I was comfortable, I was able to do my best work, don't ever have any issues with headaches, discomfort, so on. So I was noticing so many things that I never saw. It was a whole different world. Just from the minute I looked at my fingernail, and I was able to see texture that I didn't know existed. Same thing happened in the mouth, bubbles, porosities that I wasn't seeing. So I remember Pascal quoted saying something like, if you want to find a depressed dentist, find a dentist wearing 8 times magnification. This was in dental school. And the reason he was saying that is because you see every little bubble, every single porosity, but it's challenged me to address those. And now I hold myself to the standard of whatever I see is what I treat. So I do think it's a very important part. I couldn't do it without it, but one of my mentors in dental school, Dr. Laura Sabetti, changed my world, because he, with no magnification whatsoever, could spot decalcification. I'm not even exaggerating on this. He could spot decalcification standing over your shoulder on the distal of a molar, on the margin, just literally standing over your shoulder. I don't know how he did it, but he was incredibly gifted, incredibly talented, must have had eagle vision. So everyone's different, but I think as an average, we probably need to do that. And he's known for that ability and his hand skills. But when it comes back to every other dentist that I've met, magnification's been an integral part of their success.
That's great. The next question is regarding ozone. What are your thoughts on using ozone as part of the biomedical dentistry protocols?
I have done a fair amount of research on that topic, because it comes up as a question both by patients and by dentists in my courses. And what I always come back to is a couple of things. I try to keep the logic as simple as possible. So one, does it solve anything I'm currently experiencing? Am I having a high rate of root canals because of leaving bacteria behind? Am I having failures because of bacteria, recurrent decay, anything along those lines? Am I routinely leading to root canals because of complete caries removal? So no, none of those are issues that I have. And 2, ozone in about half the papers I read on the topic affected the bond strength, which makes sense because of air inhibition, introducing oxygen radicals. So I don't like when you see about half the publications on the subject matter show a reduction in bond strength. Having any advantage of killing additional bacteria at the expense of bond strength is counterintuitive to me. And on top of that, the way I understand the caries process is, and as it's supported in the literature, is that a source of nutrition is necessary. Leaving bacteria that's sealed, doesn't have a source of nutrition, deactivated, will not result in the continued caries process. So getting a good seal, disinfecting, deactivating, and sealing of bacteria in the deepest portions is totally fine with me, compared to trying to fully sterilize. Plus the bonding agent SC Protect has that additional ability. So when patients are concerned about that, or oftentimes when I am very deep very deep in a caries removal process, I oftentimes will favor SC Protect for that reason.
Here's an interesting question. I don't know if I've ever really heard it answered, but is it possible to preserve a tooth better with biomechanics if it's already been crowned?
Yes, patients ask me all the time so they're like, did I miss, they come to me and they're like, I already got a crown. Is it too late for biomedic dentistry? And the answer is no, because biomedic dentistry is the idea is to do the best version of any restoration possible, bringing it to the standards of an intact tooth. So with a crown, if you already have a crown, I want to give it the best seal, the best marginal integrity, high bond strength, minimize leakage, sensitivity, pain, all those things, and even allow stresses yet again to mimic the normal function and biomechanics of an intact tooth. And a non-bonded crown does an acceptable job of restoring a tooth, or does an acceptable job, but it doesn't mimic the natural tooth biomechanics. So my thing is, I won't replace a totally intact crown for no reason. But if we need treatment, am I just doing a standard crown? I try to tell the patient, no, it's not a standard crown. I'm still doing immediate dentin sealing, resin coating, doing everything I can to make it the most biomimetic, best possible crown, but not to the extent that you need to replace every perfectly sealed crown I see, or perfect margin crown that's in your mouth. Those I'll leave alone unless they have symptoms or problems or defects.
Okay, I think we have one more question here, unless any others flow in real quick. What disinfectant would you recommend to use over ozone?
SC Protect. Short of that, I don't use. I've done many cases with no disinfection, just doing caries removal endpoint, calling it quits, getting a perfectly clean, sound peripheral seal of Dentin. There's a whole article on that by David Allman and Pascal Monnier, and it's available online for free. You don't need a subscription to anything, but in the deepest portion where you stop your caries removal process, I have done everything from just sealing it with OptiBond FL because as I explained, the bacteria needs a source of nutrition, and that's mentioned repeatedly in the literature on cariology. But if I do want to get that disinfection, for me, it's SC Protect or nothing. I mean, I don't think it's mandatory.
Okay. Another question. I know a lot of people are doing indirect restorations, putting the restorations in with a heated composite. What is your feeling on doing a technique, kind of like what you've been doing versus using a Panavia as a bonding technique for indirect restorations?
Panavia is, I think, one of the best cements on the market, at least from my limited experience and a lot of top clinicians that have used it for many years, but I don't have firsthand experience with it. A lot of firsthand experience with it, very limited, probably cemented less than 10 restorations with Panavia. I use heated composite almost exclusively. The few times I used Panavia had to do with either feeling like I wouldn't be able to seat the restoration, but I've refined my technique so that even those types of restorations I can still seat with warm composite. So I think the major question is here, what's my opinion on the success that comes from it? Well, the modulus is lower, and it's well documented that higher modulus materials protect the restoration. So having a core of higher modulus and even a cement that's higher modulus will minimize the ability for your restoration to crack or fracture. Panavia is not low, but it's lower. Second is, for me, the driving force is it's not much easy. Like, I really have gotten used to and prefer the cleanup method of warm composite, taking my time, verifying margins. I'm not very comfortable with dual cure. And one of the times I did use Panavia to cement, my assistant handed me the wrong restoration. By the time she gave me I realized it didn't fit. Had isolation perfectly in place. She gave me the next, I said, no, wrong one, gave me the right one, but we used the same tip. The material was already setting, got it halfway in, and it was the beginning of cementing 10 restorations on a patient, one of my most uncomfortable times in dentistry, because I had to get through another 6 hours or so of cementing. So I finished, and she said, is something wrong? I said, no, everything's fine. And at the end of the appointment, I explained exactly what's going on. We redid it, but it was something that I don't appreciate the dual cure aspect isn't for me. If it works for you, I don't think it's the difference between success and failure in biomimetics, but I just think that the restorative composite is even better, especially once you get over the hump and the learning curve or getting used to it. Most people who've used it agree with that.
Another question just came in. Do you prepare half a millimeter deeper to make room for the IDS and the resin coating in minimal depth restorations or previous minimal prep crowns like Emax?
Not additional. So that, but I see where you're coming from. So I always look at, so one of the big mistakes you can make on these restorations is when you have finished your preparation, now you do immediate dentin sealing, resin coating, take your impression, and now you're like, I only have half a millimeter of space left. So with that, you're like, what did I do or what should I do? And the answer shouldn't be to prep more. In those cases, I tried to, one, avoid it by maybe not putting half a millimeter of resin coating. Optibond FL, you can do 80 micron to 100. So another reason why in cases like that, veneers sometimes into dentin or posterior minimal reduction into dentin, sometimes using Optibond FL with the 80 to 120-ish film thickness is optimal there. Alternatively, I've also done quite a few cases where I do 2 layers of SC Protect, first layer cured, second layer. I know when I'm coming back to aerobrate, I'm going to be removing some of it. That also has worked well, but I do think the studies are showing that having a resin coating on top is going to give a better performance. So that's when Optibond FL, for example, is a good option for those situations. Haven't seen any problems with doing 2 layers, but I think Marco Carvalho just did a recent paper, and I think they showed that with a self-etching system, not using flowable composite on top of it does affect the potential bond strength. So other thing you can do is use a thinner restoration, a restoration optimized for being thinner. For example, in some of the research Pascal has done, they looked at Lava Ultimate as ultra thin occlusal veneers. So in those cases, you can also do something as low as 0.6 with good results, but I would still always be shooting for about 1.2 millimeters or more, even in those scenarios, just to have a little bit of extra cushion and protection. And if I need to prep barely more for that, so be it, but not systematically half a millimeter extra.
I have a very engaged audience. The questions keep pouring in. But so another follow-up question to what you mentioned discussing before about the heated composite. The question is, with regard to heated composites, do you have any issues with damage to the pulp from the heat? And also, are there any issues with the composite being uncured if it's in a deep restoration?
Good question. So I have no issues with damage to the pulp from heat because on 10 or so years, I haven't had any issues traceable to that. I know that's not a great answer. I don't know, to be honest, if there's research on it, but this is what I was taught. And even my mentors had done this way. So sometimes I feel like you don't necessarily need research for every single thing, but I haven't experienced even a high rate of teeth that I restore resulting in damage to the pulp from heat. And this is a passed down technique from my mentors. So not concerned about it. I can look for some research on it. I think there isn't, but there might be. Then the other thing about uncured, if it's a deep restoration, that is a little more easy to address because my goal is to not have 5 millimeter thick restoration. So when I'm looking at something, first of all, I cure from all different sides, buccal, lingual, occlusal, interproximal, about 3 minutes of total curing. And that means you're not necessarily far from any given surface if you're getting the right angle. If you're only doing occlusal, you might be very far from certain surfaces, but if you get all different directions, you can really alleviate that. And the second thing is, I think you can cure up to about 4 millimeters effectively, but I specifically try to avoid having restorations where I am 4 millimeters in any given direction by building up. It's part of the step called the bio base, where if you have these deep areas, undercuts, you put a little bit of composite down as a base in that area. It has a lot of other advantages anyway, in terms of the shape of the preparation, blocking out undercuts. But I basically don't routinely have these issues because I deal with them on the preparation day.
Another question, is there a limit for the thickness of the composite used for deep margin elevation?
Practically, yes. Literally, no. So your goal isn't to do the highest elevation possible. So if you have your bone level back, so sorry, the questions are coming in. I was getting distracted. If the bone is at the normal level, you have no bone loss, then realistically, the goal of margin elevation is to bring the margin either equigingival or 0.5 millimeter subgingival, basically to a point where when you isolate it, you can, when you place isolation, you can deliver without expecting any additional bleeding, contamination, which wouldn't be possible at the deepest portion. So let's come back and say that you have normal bone level. It's probably 2 or 3 millimeters absolute max. So because if you look at the contour going from the crest of the bone up to 0.5 millimeter subgingival, you're probably not going to have more than 2, maximum 3. Doing more adds more and more polymerization stress, and using the deep margin elevation technique is one of the techniques that minimizes stress on that area that's difficult to bond to. The dentin in the box area is not known to, it's known to be one of the more difficult areas based on tubule direction, moisture content, isolation, you name it. So keeping it 2 to 3 millimeters or less is good. The average margin elevation I do is 2 millimeters. The other, sometimes they're only 1, but average is about 2. If you have a lot of bone loss, your goal isn't to bring it back to where the old CEJ was. If you have bone loss and you can isolate and you can deliver and cure from the side, same thing applies. You know what I mean? You don't need to elevate your margin back to the CEJ level. You need to elevate it to the gingival level, give or take.
What is the purpose of using glycerin, and how would you use it?
Purpose of glycerin is to remove the tacky surface on the occlusal or on the surface of any polymerizable resin, because those areas, when they're exposed to oxygen, have air inhibition. The oxygen radicals interfere with the polymerization process of resin materials. So when you cover with the glycerin, you displace the oxygen. And when you displace the oxygen, you're allowing that surface to cure more fully. It's still not 100%. It's still not 100%, but it is more cured and more polymerized, and it's very important for the margins, which you don't want to have ditching or removal of any material there. And it's also important when it comes to immediate dentin sealing and impression taking, where you don't want to have any reaction with your impression material sticking to the impression material, or even a higher chance of your temporary adhering to that area.
Okay, well, I'm going to wrap up the questions now. We had a couple hours of really awesome questions. I'm speaking for everyone. We really appreciate you taking the time to answer these questions in such great depth. Really appreciate it. I'm going to encourage every single person on this call to register for Dr. Nejad's next webinar, which Carla is going to post in a second, so you can see the information on that. It's coming up in a couple of weeks. So we'll want everyone to be a part of it. And of course, I highly recommend everyone check out his Nejad Institute to learn more about the kind of courses he offers, because he has some amazing information and courses to help further everyone's knowledge on biomedical dentistry. And of course, if you're not already a member of the Academy of Biomedical Dentistry, please go and register. There's so much, a wealth of information you could learn from the people who we're associated with, such as Dr. Nejad and his mentors. So I'm going to turn it over to Carla. Thank you again so much for everything you do for us.
Thank you so much. Thank you. Thank you. Again, echoing the words of Dr. Mark Lazar. Thank you from the bottom of our hearts, Dr. Matthew Nejad, for answering and doing a live question and answer for us today. It was amazing. Such a fun way to switch up a little bit of the Zoom calls and webinars. So thank you very, very much. That was fantastic. For everyone that is on the call and is doing CE, let me share my screen here, and we will post the code up here. I've also copied and pasted this in the chat bar. The code is MN061221. So you will need that to claim your CE. when you get the email. The email will be sent to you in a few days with your CE certificate, and you'll want to use this code. We will also do our polling question really quick for our CE. I will do that now. If you could please answer this. Always a little humor from our friend Matt Miller, who's not with us today.
Oh, thanks, Matt.
Wonderful. Thank you so very much for all of you attending our webinar. We will be having our next webinar. It is coming up on June 26th. It is not next Saturday, but in 2 weeks, June 26th, 4 p.m. Eastern Time, New York. We will be doing a course on Introduction to Biomimetic Dentistry. And that is going to be amazing. You can register now at aobmd.org/webinar. Again, that is aobmd.org/webinar. Register now, get your seat. We will even, through today at midnight, we will give you $10 off. If you use checkout code ABD10 at the checkout, you can receive $10 off the course on June 26th. So please make sure to register. If you are not a member of the Academy of Biomimetic Dentistry, it is very easy to become a member. Just visit our website at aobmd.org. Benefits. When you are a member, you have access to the webinar recording database. You can have a listing on a database. That listing will be for your practice, and that is for patients to find a biomimetic dentist. There's a community of biomimetic dentists. You've met some of them today on the Zoom call. You can also access member level content, videos, and case studies. The Academy of Biomimetic Dentistry also offers an accreditation and a fellowship program for those seeking to really hone in on their biomimetic skills. We do have some additional CE from some of our trusted scientific advisors, and attending their courses that is required in a few of these programs. There are also an advanced membership option. This will help you to market your dentistry and biomimetic dentistry to your patients. We provide some additional marketing materials, some videos that you can use in your practice, in your lobby, brochures for your patients, just to help you to market biomimetic dentistry to your patients. So if you have not, please, I do urge you to join and support the Academy of Biomimetic Dentistry, and just go on, become a member. It's easy, aobmd.org, and you can click become a member. Thank you again very much, Dr. Matthew Nejad. We were so lucky to have you on the call today. It was awesome. I'm sure everyone out there is giving us a huge round of applause, and excited that you were able to share with us today. If you have any questions, feel free, always email us at info@aobmd.org. We'd be happy to offer you any help. I do see somebody has just said the ABD10 code is expired. I will go on the back end of the website and I will fix that. I am not sure why that's happening. So just try back here in just a few moments. We'll make sure that that's rectified. And again, thank you. Please go online, register for the course, and have a great, safe, and happy weekend, everybody. Thank you again for attending.
Yeah, take care, everyone. Thank you. Thank you again. Had a great time, and I'm glad you all enjoyed it. Have a great rest of your weekend. Bye, everybody. Take care.
Thank you, everyone. Have a great time.